Campbell is here from home. She presented because of respiratory distress. I guess she was at Cheeside Hospital a few days ago, the 30th, for a hypertensive urgency, which they changed her blood pressure medications around a bit for. So she is here for a wide differential, not really completely sure what's going on. So it's possibly CHF exacerbation and NSTEMI COPD exacerbation versus aspiration pneumonia. So they're kind of treating all of those currently, so it's interesting. So we'll start one by one. So first off, her NSTEMI possibility. So they started a beta blocker in her yesterday, metoprolol on top of her Coreg, which she's already on a super high dose for, 50 milligrams BID because of hypertension. Mm-hmm. So that's probably not the best idea to have metoprolol and carvedilol because they both have beta blockades. So, especially if they're considering other things in their differential, like COPD exacerbation or CHF exacerbation, you wouldn't want to start a new beta blocker. But NSTEMI, that is definitely an indication for that. So, I mean, I would not suggest doing both of those, so probably stopping the metoprolol.
What's your concern with beta blockers in those other two? The
so COPD would be bronchospasms, okay. And CHF, if she's fluid overloaded, then you don't want to start. If she's having acute CHF exacerbation, you wouldn't want to start a beta blocker during it because it causes basically your heart pumps too much and then your fluid is just all, I don't know.
So it can help decompensate. Okay.
It makes your heart pump too hard for the fluid and it just messes up that whole balance.
Yeah.
That's, I don't exactly know the correct terms for it, but yeah.
Okay.
Yes. Okay, so that, and then with the NSTEMI, they also started her on enoxaparin, which we kind of already talked about, the dose being 45, which is indicated because it's the 1 milligram per kilogram for NSTEMI, and she's over 75. And then they also started aspirin, so that would all be appropriate for an NSTEMI diagnosis. So,
do you know what the dose, how the low NOx syringes come? Do you dispense those very often?
So they would be. So she would have the 40 for 0.4 ml. So then you would have to be giving her a bigger syringe. So then you're wasting a lot, probably. I don't know what you guys do here, but
yeah. Do you know how the bigger syringes have the notches in them too, so you can give less?
So you could give less, but you also you're gonna waste a lot then. So they should probably change it.
Yeah, there's waste, and then there's also how sure are you that you're actually giving that amount.
Right.
So she could be, how's her renal function?
Not good. Her renal function, her creatinine clearance is around 15.
Right.
So it's not good.
So given that, and if you had to round the dose.
So you'd round it down to 40.
Okay. What was her weight?
Her weight was 45.
Okay.
40, well, I don't know. It's between 42.5 and 45. I don't know which one they actually weighed her for.
The one, so we can pull it up in here later, but there's one that'll have estimated and one that says measurement.
The
42.5 is measurement.
So then her weight would be 42.5.
Yeah.
So then it would definitely probably 40.
Yeah.
100%. You should be at 40 for that. Okay. So that's that. Alright, other problems. So let's go other ones. So the possible aspiration pneumonia looks pretty probable because of her chest X-ray. So for that, they started her on, they tried to start her on Moxie, but then they changed it to Unison, which is more appropriate, and azithromycin. So the Unison, let's see, where did I write this down? So the Unison is good. That was recommended for, so problem with her, though, is it could be hospital-acquired pneumonia, because she was in the hospital. It is about 3 days later, which would be a presentation of possibility of catching it there. So that brings up a whole lot of other organisms that Unison probably isn't going to cover, so basically that would be Pseudomonas. It doesn't have very good Pseudomonas coverage, so if we're concerned about that, although I'm not completely convinced it's infectious because her white blood cell count hasn't really risen. She doesn't seem to have much of a temperature. I don't know. I guess it's the chest x-ray we're going with, so.
That is a really good thing to look at, the clinical picture.
Right.
And.
So, it didn't, I don't know, I'm not entirely convinced of that.
What do you know about, how old is she?
So she's 87, so unlikely, it's possible that she would have none of those
Exactly, yeah. So she could just not be able to mount an immune response.
Right.
But so it's good to look at those, and then like you said, you did have something on her chest x-ray, which do you know why, looking at that, they were thinking about aspiration?
Because it said it in the findings, but it was something about the right lobe, and then it just being like one little part of that, like, so that it was aspiration. I don't know, it was something along this.
Yeah.
And it was unilateral, I think. It was just on the right, so that also said.
Yeah, and so the reason that they think that looks like aspiration is because on the right side of your lung, your first bronchial branch is higher. So when you aspirate, it just whips down the right, and then there's just this streak where that comes out.
Right.
So given that,
So,
I would be okay with just covering her for aspiration for now, unless she starts to tank.
Right. So they started her on unison, which good aspiration pneumonia coverage. They also started her on azithromycin. I guess they're concerned about atypicals, but I also noticed her QTC was 639 yesterday. Yeah. Yeah.
Yep.
So that doesn't seem like but there's not really, if they're really concerned about atypicals, then I couldn't think of any. Like, I mean, we could do a broad spectrum antibiotic instead of those two, but I didn't know.
What else? You mentioned something else that their differential.
COPD exacerbation. Right. So that would be azithromycin.
Right.
That
do
would
you
be
remember
the indication for using it for atypicals,
possibly? Do you remember when we had that discussion on rounds?
Anti-inflammatory also.
Yeah, so that's why it's number one.
azithromycin.
Clearly in her with her QTC, even though it's number one because it has the anti-inflammatory effects, like you said, not the best option. So what are some other COPD
So you could do
treatments?
Moxie, but that also has the whole QTC problem, so
Correct.
that is not a good option. You could do, let's think, you would do
Two other PO ones we talked about.
Doxy,
Mm-hmm.
and could you do clindamycin?
There was one that is kind of like the unison.
Augmentin.
Yeah.
We always talk about Augmentin, and I always am like, no. I just don't think it's like a strong enough drug.
Yeah. I know. Yeah. So, given all of that that we just talked about, what would be your plan for her antibiotics?
So, unison's basically like Augmentin. Augmentin at least. So, then I would think she'd just be okay on the unison for now. Like, she doesn't need the azithro, especially since she doesn't look, her labs don't make her look super sick. I don't know what they think.
Okay. Yeah.
So
I think given that it's most likely aspiration, the unison will cover a bit of COPD exacerbation anyway, and her QTC was over 600. I like your idea of stopping with azithromycin.
Okay.
Alright, next problem.
Alright, so the next problem was what we were kind of talking about, the COPD exacerbation. So they started her on steroids for that. They started her on Solumendrall 40 milligrams IV Q12, which, given her other problems of possible heart failure, possible infection, does not seem like the best idea to be putting her on such a large dose of steroids, especially since the recommendations, it's PO-Pred 50 milligrams daily. So they're like doubling that dose. So I didn't know if like her lungs just sounded super, I don't remember the correct lung word for it, but super congested to the fact that they thought they needed such a high dose, but if they want to continue steroids, I would suggest decreasing them.
Okay. What concerns you with her other...
So her other problem, her infection, if she's actually having an infection, steroids are not going to help her cure the infection. Also, if she's having fluid retention, which would be part of the possible CHF exacerbation, that could also cause fluid retention and increase her blood pressure, but she's not having that problem, so increasing her fluid. So.
Yeah. Definitely things we're worried about. Do you know what the possible dose ranges for methylprednisolone are?
Like the possible dose ranges?
Yeah. Or how it comes in those vials. You probably don't see those in giant
idea.
So they come in either 40 ml vials or 125 milligram vials. So 40 Q12 is pretty low for methylprednisolone.
Right.
Although if you convert it to prednisone, it's not quite a 1-to-1, but we generally end up doing that. So that would be about prednisone 50 BID. So if we want to keep her on IV, at least maybe decreasing a little bit.
Yeah.
But
Could we go daily?
Yeah. But we can see how, like you said, her clinical picture, see how they thought her lungs sounded in physical exam today.
Right.
It might be worth it if that's, the number one thing on their differential.
Right, like if that's their biggest I just feel like they need to pick a biggest concern. Okay.
Yeah.
Other problems was her fluid status, so we kind of alluded to at some point she was fluid overloaded and was put on furosemide or Lasix. She was given 40 milligrams once, and then it looks like they're going to do 20 milligrams IV, but continuing daily. So just to watch that is kind of my thoughts there. They normally do the fluid stuff. I don't really have a suggestion other than if they want to. She wasn't on mine. So just
Was she on that at home?
She was not on it at home.
Okay.
So that's a new drug.
Does she have, so you said CHF exacerbation?
Yes, so she does have a history of, she had, but not, I think she had, a family said she had, at one point they thought she had acute CHF exacerbation, but there wasn't really a lot of history about that I could find at least, so I'm not entirely sure.
Okay.
That seems like a low.
I didn't see it on her problem list, and I didn't see an echo. I didn't look too far.
Yeah, she had gotten an echo, I think it was her, she got an echo, and it was like, her ejection fraction was pretty high, but I think she had had an acute CHF exacerbation.
So it could have been diastolic dysfunction.
Yeah.
Okay.
But
All
anyway,
right.
so that's that. Okay, so those were her big problems. Other things, we talked about her enoxaparin for DVTs. They stopped the heparin, that was good. Her QTC, really the azithromycin. I guess steroids. Can't steroids increase your QTC too? Maybe not.
There might be a small risk. It's
Small
not one of the
risk.
ones that jumps out at me, but we
Right.
can look it up.
Yeah. Okay, those ones. And then she was also on oxycodone at home. It looked like she was on. I did not get to talk to them yesterday. I went to see her, and the first time I was in there, they were trying to put her on BiTop. I was like, no. And then I went back later, and she wasn't there, and her family was all standing around in a circle, consoling one another. So I was like, okay, I'm not gonna go in there either.
Okay.
Anyway, so I didn't med rec her yesterday, but it looked like when she left, she decided she was on Oxy 5, 1Q4, one tablet Q4 hours. So she's not on that here, and I didn't know what.
They added it back.
Oh, did they? I
PRN,
didn't see it.
Yeah.
Okay, never mind. What was that? Oh,
Good
there
thought.
it
We
is.
don't want our poor Jerry's to
I
be in pain.
know, right? Oh.
Especially since, what do you know about delirium?
So it would be an increased risk of delirium.
Yep, untreated pain.
Right. So, okay. So, anyways, that was on there. And then she doesn't have a bowel regimen, especially if she's going on the Oxy. So, I would suggest Miralax, but they kind of pick between Miralax and Tenor.
What would make you pick one or the other?
So, I mean, Tenor's technically better for opiates, but Miralax, she doesn't seem to be acutely constipated, so I'm not super worried about. Well, I guess she could be. I'm not really entirely sure, but
Yeah, we haven't seen her long enough to see yet, right?
right. So she could have either.
Yeah.
Anyways,
So you're right, Senna is more effective for opiate-induced constipation. In her, it might be more chronic until we know how much she uses the oxycodone, or if she's even constipated right now. But it's definitely something we can keep on our differential, again, because of
delirium.
Yes.
Yay.
And because constipation is not comfortable.
No.
So.
And it sounds pretty awful. Anyways, I think that's all I have for
Okay,
her.
good. So we're gonna stop her extra beta blocker.
Yes.
Try and stop her azithromycin.
Right.
Med rec her this afternoon.
Yes.
Change her enoxaparin dose.
Right.
Anything else?
No. So do you have that? Because you mentioned that you can the pharmacy can automatically decrease doses.
Oh
Should we
yeah, I
round
guess
it
I
so
could
you-
just change
you
her.
just
I
don't
can
put
just
them?
round it. Yeah, we'll let them know that we're doing it.
Okay.
Yeah, so I guess you don't have to.
Okay.
Okay,
All
we can be
right.
done.